Good afternoon, everyone. This is Matthew Fan from the Integrated Care Resource Center, or ICRC. Thank you all for joining us today for this ICRC webinar on using exclusively aligned enrollment to integrate Medicare and Medicaid benefits for dually eligible individuals. Next slide, please. Before we get started today, I'd like to just quickly go over a few logistics for this call. For those of you joining us by phone, you can view the slides by logging into Zoom. You can find the directions for doing this in the calendar appointment for today's webinar, which you should have received via email after registering for this call. Additionally, we will be recording this call so you can revisit today's presentation or share the recording with colleagues who are unable to join us today. We'll be sure to send you a link to that recording and the slide deck later this week. And to eliminate all background noise, all attendees' phone lines will be muted during today's presentation. Additionally, we'll have a Q&A segment at the end of today's webinar, but we will keep the phone lines muted. So we ask you to submit questions via Zoom using the Q&A icon at the bottom of your screens. You're welcome to submit your questions at any point during the webinar. And if you'd like to use the closed captioning feature, please click on the More option in the Zoom toolbar at the bottom of the screens and select the Captions option. You're also able to edit the caption settings to adjust the text size by going to the Subtitle Settings option in the same area. And finally, as you leave the webinar today, a short evaluation will pop up on your screens. We'd really appreciate if you would take just a minute to share your feedback with us. Next slide, please. Our presenters today will provide a brief overview of DSNPs and an introduction to exclusively aligned enrollment, or EAE, followed by a summary of benefits of EAE, a description of 3 contracting strategies that states can use to achieve exclusively aligned enrollment, some key considerations for states planning for and implementing EAE, an overview of the key steps involved in this implementation, and examples of a few specific states' technical processes for implementing exclusively aligned enrollment. Next slide, please. We will hear from 4 ICRC subject matter experts today, all of whom are from Mathematica. We have Caitlin Murray, Ryan Stringer, Haley Gallo, and Diane Bieber with us today. And with those brief intros out of the way, I'll turn things over to Caitlin to begin today's presentation with a brief refresher on DSNPs for you all.
Excellent, thank you, Matthew. Okay, so before we dive into the nuances of exclusively aligned enrollment, I'm going to give a brief overview of what a dual eligible special needs plan, or DSNP, is. Next slide, please. So DSNPs are Medicare Advantage plans that only enroll dually eligible individuals. There are several requirements that DSNPs must meet. These include the requirement that DSNPs at least coordinate Medicaid benefits for their members. They must also develop a detailed model of care that describes how the DSNP will meet the needs of the population they cover and serve as a framework for the DSNP's care coordination processes. They must have contract-level enrollee advisory committees that solicit input from DSNP members on ways to improve access to covered services, coordination of services, and health equity among underserved populations. And starting in 2024, they must include questions about social needs and annual health risk assessments. Next slide, please. So all DSNPs must have a contract known as a State Medicaid Agency Contract, or SMAC, with the State Medicaid Agency to operate in a state, and those contracts must include certain minimum contract elements. States can also include additional requirements in these contracts that go beyond those minimum requirements, and many states incorporate additional requirements in their SMACs with DSNPs to improve administrative, clinical, and financial integration of Medicare and Medicaid benefits for DSNP enrollees. It's also important to remember that states are not required to contract with DSNPs, and states can deny contracts to any potential DSNPs. Therefore, states may choose to contract with only certain DSNPs if desired. Next slide, please. So while all DSNPs must meet the requirements that I just described, the level of integration at which they operate can vary. So coordination-only DSNPs are the most basic level of DSNP, and these DSNPs must at least coordinate Medicaid benefits for plan members, and they must notify the state or the state's designee of hospital or skilled nursing facility admissions for a group of designated high-risk enrollees. With some coordination-only DSNPs that may cover some Medicaid benefits for their members in some states, CMS does not require these DSNPs to cover any particular Medicaid benefits. Highly integrated DSNPs or HIDE-SNPs must cover Medicaid behavioral health services and/or long-term services and supports through the DSNP or a Medicaid managed care plan that is offered by the same parent company as the DSNP. Starting in 2025, to qualify as a HIDE-SNP, the parent company's Medicaid contract with the state will need to cover the entire service area of the DSNP. And to qualify as a fully integrated DSNP or FIDE-SNP, the legal entity operating the DSNP must be capitated by the state to cover at least Medicaid primary and acute care services and LTSS, including coverage for 180 days of nursing facility care. And the DSNP must use specialized care management and network methods to coordinate care for high-risk beneficiaries. In 2025, FIDE-SNPs must operate with exclusively aligned enrollment, and the parent company's Medicaid managed care plan will need to cover the entire service area of the DSNP along with other requirements. Next slide, please. So if you're interested in learning more about DSNPs, we've included links to other relevant ICRC webinars here. The first two ICRC webinars are from our December Working with Medicare series on DSNP contracting. Those webinars provide introductory information about DSNPs and DSNP contracting for states, as well as information about how states can leverage DSNP contracts to better coordinate and integrate Medicare and Medicaid benefits for duly eligible individuals. Today's webinar is part of a series of 2023 ICRC webinars on some more advanced DSNP contracting topics. Other recent webinars in this series include a February 2023 webinar for states on selectively contracting with DSNPs to promote alignment between DSNPs and Medicaid managed care plans, and an April 2023 webinar on leveraging the DSNP model of care to enhance enrollee care coordination. Next slide, please. Okay, so now we're going to pivot to an overview of exclusively aligned enrollment. Next slide, please. So let's start with understanding what aligned enrollment is. So aligned enrollment occurs when a duly eligible individual enrolls in a DSNP and an affiliated Medicaid managed care plan offered through the same parent company in the same geographic area. When a single parent company offers both a DSNP and a Medicaid managed care plan in the same area, those two plans are known as affiliated plans. So to help show how aligned enrollment can simplify administration of Medicare and Medicaid benefits for duly eligible individuals, we've provided two diagrams on this slide. The diagram on the left shows a scenario where some duly eligible individuals have aligned enrollment, while others have unaligned enrollment. So for example, when someone is enrolled in both Company A's DSNP and Company A's Medicaid managed care plan, they have aligned enrollment. However, if someone is enrolled in Company A's DSNP and Company B's Medicaid managed care plan, they have unaligned enrollment. Additionally, in the diagram on the left, Company C operates a DSNP without an affiliated Medicaid managed care plan, and therefore none of Company C's DSNP enrollees can have aligned enrollment. In contrast, the diagram on the right shows a scenario where all duly eligible DSNP enrollees have aligned enrollment and none have unaligned enrollment. As the diagram illustrates, the situation is much simpler for DSNP enrollees to navigate and for states to explain to potential DSNP enrollees. If a state requires all DSNPs to have an affiliated Medicaid managed care plan in the same service area, then all enrollees at least have the option to choose aligned enrollment. States can also require DSNPs to have aligned enrollment with their affiliated Medicaid managed care plans, which I'll talk about on the next slide. Next slide, please. So when a state DSNP contract limits enrollment in the DSNP to full benefit duly eligible individuals who receive their Medicaid benefits from the DSNP or from an affiliated Medicaid managed care plan offered by the same parent company as the DSNP, this is called exclusively aligned enrollment. The benefit of exclusively aligned enrollment is that it opens the door to several strategies to integrate coverage of Medicare and Medicaid benefits, including fully integrated enrollee materials, single ID cards, and unified appeal and grievance processes. Next slide, please. So lastly, Applicable integrated plans, or AIPs, are D-SNPs that operate with exclusively aligned enrollment and cover at least certain Medicaid benefits. So there are two ways that a D-SNP can qualify as an AIP. The first is to be a HIDE-SNP or FIDE-SNP with exclusively aligned enrollment, and the second is to be a COD-SNP with exclusively aligned enrollment that covers Medicaid primary and acute care benefits and Medicare cost sharing, and at least one of the following additional Medicaid benefits, including home health, medical supplies, equipment, and appliances, or nursing facility services. AIPs must implement unified plan level appeal and grievance processes that are designed to be easier for plan members to navigate than separate Medicare and Medicaid appeal and grievance processes. And with that, I will hand it over to Ryan.
Thanks, Caitlin. Next, we'll cover some of the benefits offered by EAE. Next slide, please. EAE creates an environment that can be used to promote enhanced beneficiary and provider experiences. The graphics on this slide represent specific health plan features that states can enable through EAE. It's important to keep in mind, though, that these features do not occur automatically when a state implements EAE. In most cases, states will need to require these features within their SMACs and/or work with their D-SNPs to implement each of these features. Some examples of benefits that EAE enables include comprehensive, coordinated benefit packages that cover all or substantially all Medicare and Medicaid benefits. D-SNPs that operate with EAE may also be able to issue integrated benefit determinations and offer integrated appeal and grievance processes. In an integrated appeal process, an enrollee does not need to know whether a particular benefit was covered by Medicare or Medicaid to file an appeal, for an example. EAE also allows D-SNPs to provide a single set of Medicare and Medicaid informational materials to enrollees, such as plan enrollment documents and summaries of plan benefits. This single set of materials can comprehensively explain all of the benefits that the enrollee qualifies for within the plan and any cost sharing involved, so that the enrollee doesn't have to navigate separate information about Medicare benefits and Medicaid benefits. EAE also supports enhanced care coordination, either through streamlined collaboration and communication between multiple care coordinators serving the same enrollee, or through situations where an enrollee receives a single care coordinator for all of their Medicaid benefits. When D-SNPs operate with EAE, they can also offer enrollees a single plan ID card for both Medicare and Medicaid benefits, as well as a unified, integrated customer service line, even if the benefits are ultimately being provided by two separate but affiliated plans. These steps can help to streamline the enrollee's experience and make it feel more truly integrated. Finally, EAE supports consolidated Medicaid and Medicare billing for providers, so their experience of working with the plan can feel integrated as well. And they can submit a single bill for services rendered while receiving coverage and payment from both Medicare and Medicaid sources. Again, states need to proactively implement most of these features, as EAE does not automatically create them, but ICRC can provide individualized technical assistance on how to implement these features. Next slide, please. EAE benefits for states stem from the fact that a single parent company is responsible for all or at least most of an enrollee's Medicare and Medicaid benefits. First, EAE creates an environment of aligned financial incentives, where plans are incentivized to streamline care and reduce overall costs rather than shift costs across the Medicare and Medicaid programs. Second, EAE results in one parent company possessing all or substantially all of the D-SNP enrollees' service utilization and experience of care data, which can support plan quality improvement activities and state oversight of quality outcomes. Third, because EAE results in simpler enrollment and coverage, states may find it easier to explain the benefits offered to enrollees under EAE. Next slide, please. Next, we'll cover contracting strategies that states can consider for achieving EAE. Next slide, please. There are 3 contracting strategies that states can consider for achieving EAE. The first involves aligning DSNPs with Medicaid managed care plans offered by the same parent company as the DSNP. These are known as affiliated plans, as Caitlin mentioned earlier. The second involves contracting directly with DSNPs to cover Medicaid benefits. And the third involves requiring DSNPs to use separate plan benefit packages, or PBPs, to serve DSNP enrollees who have aligned and unaligned enrollment in separate plans. We'll cover each of these 3 strategies in more depth in the following slides. Next slide, please. The first strategy for achieving EAE is when the state selectively contracts with DSNPs that have affiliated Medicaid managed care plans and requires those DSNPs to operate with EAE. When EAE is achieved through this strategy, duly eligible individuals have 2 plans, one for Medicare and one for Medicaid, but both plans are offered by the same parent company and are required to work together to streamline members' experiences in the 2 plans. In the example on the left side of the slide, Company A, B, and C DSNPs all have affiliated Medicaid managed care plans. This structure allows for EAE. However, if, for example, Company C did not have an affiliated Medicaid managed care plan operating in the state, EAE would not be possible for Company C. Next slide, please. The second strategy for achieving EAE involves the state contracting directly with and paying a capitated rate to DSNPs instead of Medicaid managed care plans to provide Medicaid benefits to DSNP enrollees. Unlike in the previous slide, these DSNPs do not need to have affiliated Medicaid managed care plans because the DSNPs cover Medicaid benefits directly and thereby function as Medicaid managed care plans. This model can be particularly useful in states that do not have existing Medicaid managed care programs for dually eligible individuals, as it enables the state to integrate care for DSNP enrollees without having to build a whole separate Medicaid managed care program to align with the DSNPs. In the example to the right, you'll see that Company A provides Medicare and Medicaid coverage, so enrollees receive their Medicare and Medicaid benefits through the DSNP, and as a result, have EAE. Next slide, please. The third strategy for achieving EAE involves the state requiring DSNPs to use separate DSNP plan benefit packages, or PBPs, to enroll duly eligible individuals whose Medicare and Medicaid benefits are aligned versus unaligned. When states use this strategy, individuals with aligned benefits are ultimately enrolled in a single PBP with EAE. Aligned enrollment occurs when a full benefit, duly eligible individual is enrolled in a DSNP and a Medicaid managed care plan through the same parent company. At the same time, individuals whose enrollment is unaligned because they are enrolled in a DSNP and a Medicaid managed care plan through different parent companies are allowed to remain enrolled in DSNPs. States using this method can also allow partial benefit duly eligible individuals to enroll in the DSNP PBPs that exist for unaligned enrollees. In the example shown at the bottom of this slide, parent company A sorts DSNP enrollees into 2 PBPs. PBP number 1 is for company A's aligned enrollees. Specifically, PBP number 1 is limited to dually eligible individuals who are enrolled in the company's DSNP and its Medicaid managed care plan. PBP number 2 is for Company A's unaligned enrollees, people who are enrolled in Company A's DSNP and a different company's Medicaid managed care plan, as well as any partial benefit dually eligible individuals that the state may allow to enroll. Another way of looking at this is that enrollment in Company A's 2 PBPs turns on what Medicaid managed care plan covers the enrollee's Medicaid benefits. And now for key considerations for states planning for and implementing EAE, I'll turn it over to Haley.
Thank you, Ryan. So there are a number of questions and considerations that states should think through before they design exclusively aligned enrollment processes. And I'm going to walk through a few of those considerations. And I want to reiterate that ICRC is able to provide states with direct technical assistance in thinking through these considerations within each state's individual landscape and circumstances. Next slide, please. Thanks. So first, a state that is thinking about implementing exclusively aligned enrollment should consider the existing managed care landscape in the state. So for example, does the state already have DSNPs and Medicaid managed care plans that enroll dually eligible individuals? And if so, did the same parent companies operate both DSNPs and Medicaid managed care plans in the same service areas? States that have substantial overlap between DSNPs and Medicaid managed care plans owned by the same parent company can consider adopting that first contracting strategy that Ryan mentioned, which was selectively contracting with DSNPs and affiliated Medicaid managed care plans, and then requiring them to operate with EAE. But if current overlap is minimal, states may want to assess whether future procurements could create opportunities for new or existing DSNPs and Medicaid managed care plans to operate aligned plans. And if aligning DSNPs and Medicaid managed care plans does not seem like an appropriate option, states could consider contracting directly with DSNPs to cover Medicaid benefits for their enrollees. Next slide, please. And states should also consider how many dually eligible individuals are currently enrolled in DSNPs and Medicaid managed care plans in the state, both overall and across different plans. DSNPs or Medicaid managed care plans with substantial current enrollment may be less concerned about the potential for EAE to reduce their membership. And states with a large number of existing DSNP enrollees may have the most to gain from implementing EAE, as those existing enrollees could immediately reap the benefits of that shift to EAE if they choose to remain enrolled in the DSNP. And that said, states with small numbers of current DSNP enrollees could implement EAE as a way of promoting integration before growing DSNP enrollment. And implementing EAE early in DSNP contracting can help to prevent DSNPs from establishing large numbers of unaligned enrollees whose current plan enrollment could be interrupted by a move to EAE further down the road. And states should also examine how many partial benefit dually eligible individuals are already enrolled in DSNPs prior to implementing EAE, in order to determine whether the state may want to allow those individuals to remain enrolled in DSNPs, but in separate PBPs from the exclusively aligned enrollees. The DSNPs that operate with EAE may not enroll partial benefit dually eligible individuals because they have no Medicaid benefits to integrate with the Medicare benefits in an EAE model. And if a state has DSNPs with large numbers of existing partial benefit dually eligible enrollees, those DSNPs may be concerned about losing those enrollees during EAE implementation. And these states could choose to allow those DSNPs to continue enrolling partial benefit dually eligible individuals, but require the DSNPs to serve them through separate PBPs. So this enables the use of exclusively aligned enrollment in the PBPs for full benefit dually eligible individuals, while preventing the partial benefit dually eligible individuals from losing their DSNP coverage entirely. And finally, states should examine what proportion of full benefit dually eligible individuals already have aligned enrollment meaning they're enrolled in a DSNP and a Medicaid managed care plan owned by the same parent company. So states with large numbers of unaligned enrollees may sometimes find it difficult to launch EAE with all DSNPs across the state at one time. So when a state implements EAE, unaligned enrollees will need to either move to the Medicaid managed care plan that's aligned with their current DSNP or disenroll from their DSNP entirely. And because most managed care companies are likely to prioritize maintaining enrollment when possible, DSNPs that already have a high proportion of aligned enrollees will likely be in favor of state efforts to implement EAE, as will DSNPs that could gain substantial numbers of new enrollees. But on the other hand, Medicaid managed care companies that have large numbers of enrollees who are in DSNPs through a different parent company, they may be concerned about policy changes that could jeopardize that enrollment. Next slide. And as states design exclusively aligned enrollment, they should solicit feedback from key collaborators and people who would be directly affected by EAE implementation, such as dually eligible individuals, providers, and health plans, and in some cases, state legislators or other leaders. And as with any policy changes, these groups may have questions or concerns about what EAE means for them, and they may also have important ideas and feedback about ways to make EAE successful. So for example, dually eligible individuals may need some education regarding what EAE would mean for them, and they may want to understand whether they'll be able to keep their current providers. They may also be able to share opinions regarding what's most important to them in an integrated health plan. Providers may have questions about service reimbursement or authorization, and health plans may have feedback or questions about how they'll implement EAE in practice. And state legislators and other leaders may want to know if EAE will require changes to existing statutes or regulations, and what kinds of feedback or questions they should expect from constituents and how they should respond. Next slide, please. And finally, states should consider their existing infrastructure and capacity and any resource investments that may be needed to support EAE implementation. For example, does the state have existing staff who have the capacity and qualifications needed to oversee the integrated care program? And if not, what training or support might those existing Medicaid agency staff need to support EAE implementation? States should also consider what staffing and IT system resources they might need to process Medicaid enrollment transactions to align with DSNP enrollment when a dually eligible individual enrolls in a DSNP with EAE. And Diane will discuss enrollment processing for EAE in more detail in a few minutes. States that plan to align DSNPs with existing Medicaid managed care plans may also need to make changes to their Medicaid managed care authorities if they make changes related to mandatory enrollment, the groups enrolled, or how plans are selected. States planning to launch new integrated care programs that leverage DSNPs to provide Medicaid benefits directly may need to consider what Medicaid managed care authority they use to implement that program as well. And you can see ICRC's tip sheet linked on this slide about selecting a Medicaid managed care authority for more information. And again, note that ICRC and CMS can provide states with direct technical assistance on these topics as well. Next slide. So now that we've discussed factors that states should consider as they plan for EAE, we'll move on to talk about key steps in EAE implementation. Next slide, please. So the specific steps that are needed to implement EAE often vary based on a number of specific contextual factors. So for example, as shown in the green box on the left, the EAE contracting strategy that a state chooses has implications for EAE implementation. And as Ryan mentioned, states can choose to align DSNPs with affiliated Medicaid managed care plans, to contract directly with DSNPs to cover Medicaid benefits, and or to require separate PBPs for aligned and unaligned enrollees. And in particular, when a state chooses to require DSNPs to use separate PBPs to serve aligned and unaligned enrollees as its only EAE contracting strategy,
the steps required to implement EAE can be different and often more streamlined than the steps used to implement a more comprehensive EAE model. And as I walk through the next few slides, I'll highlight some examples of this. And the red box in the middle of the slide lists other examples of factors that may influence the specific steps that a state may take in implementing EAE, including whether the state is transitioning from a financial alignment initiative demonstration to a DSNP model, in which case the state may want to embed certain aspects of the existing demonstration into the new DSNP-based program. And another factor is whether the state intends to build new EAE requirements into existing contracts with DSNPs or Medicaid managed care plans, or design a brand new EAE-based model from scratch. And another important consideration is whether the state carves any Medicaid benefits out of coverage by managed care plans, because these carve-outs can present important barriers to integrate Medicare and Medicaid benefits. States with these carve-outs may want to carefully develop requirements for how DSNPs and Medicaid managed care plans will coordinate with the entities who are responsible for covering and delivering those benefits. And then, as shown in the blue box on the right, states should consider the intended service area and scope for EAE. For example, if DSNPs currently operate in limited service areas in the state, expanding statewide may require time and investment and might not always be possible if provider network adequacy requirements can't be met in particular counties. And similarly, if the state plans to align DSNPs with existing Medicaid managed care plans, the DSNPs will only have EAE in those Medicaid managed care plan service areas. So some states have chosen to have certain DSNPs operate with EAE, while allowing other DSNPs to continue operating without EAE. For example, non-EAE DSNPs may be allowed to continue operating to serve partial benefit dually eligible individuals, or a state may allow these DSNPs to continue serving current enrollees without enrolling any new members in order to more gradually transition to EAE if the state has large numbers of unaligned enrollees. Next slide, please. As noted previously, engaging key collaborators is an important step when building a new integrated care program or considering a substantial change to an existing program, such as requiring DSNPs to operate with EAE. So engaging with dually eligible individuals, providers, and plans who could be affected by EAE can help to obtain valuable feedback early and often in the EAE implementation process. And when communicating with these groups, states can also educate them about the state's goals and plans for EAE to help them understand the potential benefits. When working to implement EAE, developing an interdisciplinary work group of staff from all relevant divisions within the Medicaid agency can help to ensure that the state develops a comprehensive EAE approach that considers all necessary perspectives, and that key staff are well informed about EAE processes and prepared to support them. So these work groups can include policymakers, contracting and procurement staff, eligibility and enrollment experts, and IT staff, among others. Through early and ongoing engagement, states can educate these groups about EAE plans, solicit feedback, hear their concerns, and garner their support for EAE implementation. And all of this helps to identify and address any potential challenges and alleviate barriers to EAE implementation. And it's worth noting that states that choose to use the separate PBP contracting strategy to achieve EAE may be able to use a more streamlined engagement approach for two reasons. First, states using the separate PBP model will continue to allow both aligned and unaligned enrollees to enroll in DSNPs. So the dually eligible individuals, advocates, and providers would not likely be concerned about potential losses from that movement to EAE. They would just need to be educated about plans for the new model and how it will work. And second, states that use the separate PBP model generally rely heavily on DSNPs for technical implementation and enrollment processing. So these states may not need to develop the kind of internal planning work group that may be helpful in states that are planning more comprehensive approaches to EAE implementation. Next slide, please. So EAE implementation often requires states or state Medicaid enrollment brokers, the plans, and CMS to exchange Medicare and Medicaid eligibility and enrollment data. Depending on the EAE contracting strategy that states use to implement EAE, states should identify whether they might need to exchange this kind of information, and if so, whether they need to make any changes to their Medicaid eligibility and enrollment systems to support that kind of data exchange. States should also consider whether they will need to make any configuration changes to their eligibility and enrollment systems to match policy decisions related to EAE, such as who is eligible to enroll in EAE DSNPs, whether the state will adjust its Medicaid managed care enrollment policies to facilitate alignment of Medicaid enrollment with DSNP enrollment, whether the state will allow DSNPs to use default enrollment, and whether states want to require DSNPs to implement specific eligibility deeming periods. Some of these policy decisions may require corresponding system changes, so it's helpful to be aware of this and determine how long those changes might take and what resources may be required in the early phases of EAE planning. And if the state does make system changes to support EAE implementation, the state should test those changes before the official EAE launch date and conduct readiness reviews with any partners involved in data exchange or enrollment processing. So for example, states may want to prepare test case scenarios for health plans or enrollment brokers to process in order to evaluate their ability to successfully complete their required responsibilities under a variety of enrollment-related situations. And similar to the caveat I gave on the previous slide, states using separate PDPs to implement EAE may not need to take all of these steps, as that approach generally does not require active state involvement in enrollment processing. But it is still helpful in states that want to use that separate PDP approach to evaluate the kinds of data that will need to be exchanged between the state and its DSNPs to assess whether any new kinds of data exchange or verification will be necessary to support the EAE model. Next slide. And once a state has made decisions about its EAE contracting strategy and the data exchange processes it will use, the state should communicate its intentions with DSNPs, Medicaid managed care plans, if applicable, and other key collaborators that will be affected by EAE implementation. So for example, as the state of Indiana made policy decisions that led the state to pursue implementation of EAE in 2025, the state began incorporating language into a new Acknowledgement of Awareness section in its SMAC. And this was to make DSNPs aware of its intention to require the DSNPs to operate with EAE in 2025, among other policy changes. States should also issue clear contract language describing any relevant EAE-related data exchange and enrollment processing requirements for plans, as well as any additional administrative requirements that the state wants to implement to streamline DSNP enrollees' experiences within their plans. So this could include issuing integrated materials or a single ID card to exclusively aligned enrollees, using the unified appeal and grievance processes that are required for applicable integrated plans, and operating a single customer service line for both Medicare and Medicaid benefits. And finally, the state should carefully document its intended EAE processes, including the roles of all parties involved, the data and files to be exchanged, and timelines. So for example, states can develop tables or flowcharts to document the roles and responsibilities for verifying Medicare and Medicaid eligibility, processing enrollment transactions, confirming enrollment status, and issuing notices to enrollees. Clearly documenting the roles, responsibilities, and key resources and timelines for EAE processes not only helps all of the entities involved understand their roles within the process, but it also helps to ensure that the detailed information that's needed to execute EAE can withstand any staff turnover or changes within key staff members' responsibilities at the state Medicaid agency or other partner entities. Next slide. And states may also want to develop consistent messaging and training for all of the entities involved in EAE, such as the state, health plan, and enrollment broker staff when applicable. For example, staff who help dually eligible individuals with enrollment decisions will need to understand the implications of EAE for Medicaid enrollment and how to assist dually eligible individuals with EAE-related enrollment decisions. Customer service staff will need to understand how to explain benefits and services to current and prospective enrollees in EAE DSNPs, and IT staff may need to know how to address challenges that arise in EAE processing. And now I'll hand it over to Diane, who's going to share a few examples of state approaches to EAE.
All right, thank you so much, Haley, for that overview of key steps to implementing EAE. Over the next few slides, I will give a brief overview of the Medicare enrollment process, highlight some key Medicaid policy decisions that have implications for EAE implementation, and then highlight some examples of how certain states have approached processing enrollments into DSNPs that operate with EAE. Next slide, please. Before we look at specific states' enrollment approaches, it's important to take a minute and talk about how dually eligible individuals typically enroll into a DSNP. States need to understand these Medicare enrollment pathways when making policy decisions about EAE, because Medicaid enrollment into a DSNP or a DSNP's affiliated Medicaid managed care plan typically follows a dually eligible individual's choice to enroll in a DSNP for Medicare coverage. In other words, when a person decides to enroll in a DSNP offered by Company A, and that DSNP operates with exclusively aligned enrollment, the state will automatically move that person into the DSNP for Medicaid benefits or into the Medicaid managed care plan that is also offered by Company A. You may be wondering why Medicaid enrollment follows Medicare enrollment and not vice versa. While states have the authority to mandate managed care for Medicaid enrollees and often have policies in place to keep a person in the same Medicaid plan for a full 12-month period, dually eligible individuals have multiple opportunities to change their Medicare coverage during a calendar year. They may have an initial enrollment period when they first become eligible for Medicare, an annual enrollment period, a Medicare Advantage enrollment period, and several potential special enrollment periods that may be available to them. And states are not allowed to restrict dually eligible individuals' Medicare enrollment options or opportunities. Therefore, from a policy standpoint, it is generally sensible to allow dually eligible individuals to choose to enroll in a DSNP during any Medicare enrollment period for which an individual may qualify, and then align the Medicaid plan after the DSNP choice is made. So with that in mind, let's consider how a dually eligible individual enrolls into a DSNP. On this screen, we see three pathways. The first, on the top in green, is that the dually eligible individual initiates the enrollment into the DSNP, either by calling 1-800-Medicare or by submitting an enrollment request in the Plan Finder tool on Medicare.gov. The second pathway in the middle in red shows the individual contacting the DSNP directly or speaking with an agent or broker to request to enroll in the DSNP. And the third at the bottom in red is that a dually eligible individual is contacted by an agent or a broker who ultimately enrolls them in the DSNP. In the third pathway, it is worth noting that agents and brokers are restricted by Medicare marketing guidelines in ways that they may contact Medicare beneficiaries. However, regardless of how a person requests enrollment into a DSNP, the DSNP is informed of the enrollment request and then is responsible for verifying the individual's Medicare and Medicaid eligibility, and then for submitting an enrollment transaction to CMS if the DSNP finds the person to be eligible for the DSNP. If CMS approves the enrollment transaction, then the person will be enrolled into the DSNP, and the DSNP sends the individual initial enrollment materials. So with this understanding of a typical Medicare enrollment process, we can now discuss a couple of key policy decisions that arise for states in aligning Medicaid enrollment with Medicare enrollment. Next slide, please. There are three major policy decisions that affect how a state implements EAE. The first is that EAE contracting strategy that Ryan and Haley both talked about earlier in the presentation. If a state operates with an aligned plan model, then states need to figure out how to move a person's Medicaid managed care enrollment to align with their DSNP choice. If the state achieves EAE by directly contacting with DSNPs to cover Medicaid benefits, then states have to figure out how to move the Medicaid benefits to that DSNP. States using separate plan benefit packages to achieve EAE would not automatically move a person's Medicaid enrollment based on their DSNP choice, but instead the DSNP would base the person's PBP assignment on whether the person is in the affiliated Medicaid managed care plan or not. The next decision states need to make is whether the state will allow exceptions to state Medicaid managed care lock-in policies to facilitate EAE. These exceptions enable a Medicaid enrollment to follow Medicare enrollment when a duly eligible individual enrolls in a DSNP outside of their annual Medicaid managed care open enrollment period in states that have mandatory Medicaid managed care enrollment for duly eligible individuals. The third decision that affects EAE technical enrollment processes is whether a state will make exceptions to its existing Medicaid managed care enrollment quote unquote cutoff date policy, if such a policy exists, to align the start dates for Medicaid and Medicare coverage in an integrated DSNP. Medicare enrollment is set up as such that a person has until the last day of a month to enroll in a Medicare plan, and then their effective day for coverage will be the first day of the next plan. So, for example, if I enroll in a Medicare Advantage plan today, June 20th, my Medicare coverage will start July 1. Even if I wait until June 30th to enroll in the Medicare Advantage plan, my coverage will start July 1. However, in Medicaid managed care programs, many states use an enrollment quote unquote cutoff date, after which the Medicaid managed care enrollment would take effect the first day of the month after the following month. So, for example, in many states, if I enroll in a Medicaid plan today, my coverage would likely start August 1st instead of July 1st, just so the state has the necessary time to process the enrollment transaction and the related capitation files. When states have these cutoff dates for Medicaid, it can result in a 1-month lag between the start date for Medicare and Medicaid benefits in an EAE DSNP, unless the state takes measures to avoid that lag. The next slide shares 2 specific state examples that might help us to highlight this issue. So in this graphic, we've highlighted 2 different states' approaches to handling the discrepancy between Medicare and Medicaid start dates when someone enrolls in an exclusively aligned DSNP late in the month. On the left side of the screen, we show New Jersey's approach. New Jersey has a policy where they retroactively adjust the Medicaid enrollment date to align with the Medicare enrollment date, even when the DSNP enrollment request is filed late in the month. So in New Jersey, it doesn't matter if a person requests to join the DSNP on the 6th of the month or the 30th of the month. Both the Medicare and Medicaid benefits will be covered by the exclusively aligned DSNP on the 1st of the following month. Idaho handles this a little bit differently. They actually allow there to be a gap between the Medicare and Medicaid benefit start dates for people whose DSNP enrollments are processed late in the month. The person who enrolls early in the month, the 6th in the example that we give on the slide, will have their Medicare and Medicaid coverage both move into the DSNP on the 1st of the next month. But in Idaho, if someone's enrollment is processed really late in the month, their Medicare benefits will start through their chosen DSNP on the 1st of the following month, but their Medicaid benefits will lag behind by 1 month. Regardless of how this policy is implemented, states need to figure out how to communicate to DSNP enrollees the implications of EAE and EAE enrollment timelines for both their Medicare and Medicaid benefits. This will reduce the potential for enrollee confusion during that transition to EAE. Next slide, please. So now we're going to talk about 3 states' approaches to processing enrollments into exclusively aligned DSNPs. So let's begin by looking at New Jersey's technical enrollment process. In New Jersey, the duly eligible individual enrolls in an exclusively aligned DSNP through any of the processes that I outlined earlier. After verifying their eligibility for both Medicare and Medicaid, the DSNP submits a daily 834 file to the state for review that contains information about all enrollees for whom the DSNP has verified eligibility and processed Medicare enrollment transactions. The state then generates a modified 834 file and disposition file that are sent back to the DSNP, which confirm or reject the enrollments in the DSNP's 834 file based on the state's Medicaid eligibility data. The DSNP then sends a final approved 834 file to the state. The state then uses that file to generate EAE enrollment and capitation files for the next month. After approving the enrollment, the state auto-assigns the DSNP enrollee to the plan for Medicaid benefits and uses a retroactive enrollment start date when necessary to ensure that the Medicaid managed care enrollment start date aligns with the DSNP enrollment date for Medicare benefits. Next slide, please. Now I'll provide an overview of California's enrollment process. California has a slightly different setup as they leverage an enrollment broker for processing their Medicaid managed care plan enrollments, and they've also chosen a different file exchange system for identifying DSNP enrollment. Like in all other states, the duly eligible individual requests enrollment into an exclusively aligned DSNP through one of the methods that I've described previously. Once the Medicare enrollment has been processed, the state then identifies the individual's change in Medicare plans using the CMS Territory Beneficiary Query, or TBQ, file exchange process. The state then notifies their state enrollment broker of any duly eligible individuals who have enrolled in the exclusively aligned DSNP, and the enrollment broker processes the Medicaid enrollments into the Medicaid managed care plans that are affiliated with the DSNPs. In California, Medicaid enrollment may lag behind DSNP enrollment by 1 month if the DSNP enrollment is processed late in the month. The Medicaid managed care plan that it's affiliated with a DSNP learns about the person being assigned to their plan from daily, weekly, and monthly files issued to the plan by the state and the state's enrollment broker. Next slide, please. Now let's talk about the technical enrollment process used by the District of Columbia. DC follows a similar process to New Jersey, wherein the DSNP submits an 834 file to the district, and through the use of additional file exchanges, like New Jersey, DC is able to keep Medicare and Medicaid start dates aligned, even if enrollment occurs late in the month. Because DC's process is so similar to New Jersey's, I'd like to just spotlight a couple of key points in DC's process here. First, in addition to exchanging daily 834 file transactions, the district also sends their DSNP a daily 834 audit file that includes enrollment information for the DSNP's entire census. This helps the plans with the data validation. Second, I want to provide some details about the specific processes that DC uses to avoid the 1 month lag between Medicare and Medicaid start dates when someone enrolls in a DSNP late in the month. The district has developed a 7-day grace period for Medicaid enrollment that enables DSNPs to notify the district of DSNP enrollment transactions that took place late in the month for up to 7 days into the new month. And the district's automated process will be able to retroactively enroll the person into the DSNP for their Medicaid benefits starting on the 1st of that month. So if a person requests to join a DSNP on, let's say, June 28th, but the district isn't informed of this until July 3rd due to administrative lags, for example, the district's processes will retroactively assign that person's Medicaid coverage to their chosen DSNP effective July 1st. To ensure that their DSNPs receive appropriate capitation payments, DC also sends 2 capitation files to their DSNPs each month. They have an end of month capitation file that goes out around the 25th of the month and pays a DSNP for all the members who are enrolled as of that date. And they send a mid-month adjustment capitation file on the 2nd Tuesday of the month to send payments for any members who were enrolled late in the month. Next slide, please. So what we can see by comparing the New Jersey, California, and DC processes is that there are a number of ways to make sure information about DSNP enrollment requests reach the state or its enrollment broker, who will then process the requisite Medicaid enrollment transactions. However, states have to consider their unique landscape when making decisions and ensure that all relevant entities get the information in a timely manner and understand their role in effectuating EAE for the duly eligible individual. I think it's also helpful to note that we reviewed just 3 ways that states have made EAE work for their state, but that there may be other ways too. Each state is very different, and approaches to EAE can be as varied as the states implementing them. As you consider the possibility of implementing EAE, MMCO and ICRC are available to provide direct, one-on-one technical assistance to help you think through the considerations and policy decisions described in today's webinar, as well as to establish technical processes for EAE that will work in your specific state environment. I also want to highlight that ICRC is in the process of publishing a set of written tools on EAE that can help support states in planning and implementing EAE. We've recently published a brief introductory tip sheet that outlines what EAE is and the benefits of EAE for duly eligible individuals, providers, and states, as well as a longer tip sheet that discusses some of the key policy decisions and considerations for states planning for EAE. We also plan to publish in the near future a 3rd tip sheet that describes some of the key steps involved in implementing EAE and a set of enrollment and disenrollment tables to help states think about the roles and responsibilities of the different parties in implementing specific steps when a duly eligible individual enrolls or disenrolls from a DSNP operating with EAE. We've included on the slide a link to the webpage on our ICRC website where all of our EAE materials will be housed. So you can check out those 2 tip sheets that we've already published and watch out for additional materials which will be coming soon. Next slide, please. All right, I'm now going to turn it back over to Erin Weirlach-Mani, who will facilitate our question and answer session.
Thanks very much, Diane, and thank you to all of our presenters today. As Diane noted, we're now going to open things up for questions. As a reminder, if you have a question, you can share your questions with our panelists today through the Zoom Q&A feature by clicking on the Q&A icon that appears at the bottom of your Zoom screen. So click on that Q&A icon and you can type your question into that Q&A box, and we will be filtering through those questions as they come in and posing them to our various presenters from today's webinar, since everybody who is on the call today is on mute. So I'm going to go ahead and start with a question that had come through to me during the presentation, and we'll encourage folks to go ahead and put any questions you have in that Q&A box, and I'm going to continue to monitor it here. The first question that I had gotten during the presentation, I'm going to go ahead and give to Caitlin. It is a question that I think pertains to your presentation, Caitlin. The question was, is it possible to have some DSNPs in a state that have exclusively aligned enrollment and other DSNPs that do not have exclusively aligned enrollment?
Yes, absolutely. So a state can choose to require certain DSNPs to operate with exclusively aligned enrollment while allowing other DSNPs to operate without exclusively aligned enrollment. So, for example, some states have fully integrated DSNPs or FIDSNPs that serve full benefit duly eligible individuals and operate with EAE, while at the same time also contracting with coordination-only DSNPs to serve partial benefit duly eligible individuals. There are really just a variety of reasons why a state might want to treat some DSNPs differently than others. And again, this is one of those topics for which ICRC could provide individualized technical assistance to help
each individual state determines the policy decisions that would be best for them.
Thank you very much, Caitlin. Very helpful. This next question I'm going to give to Ryan, because Ryan, you had discussed the benefits of exclusively aligned enrollment. In your presentation, you mentioned that there are some steps that are needed to implement the benefits of EAE, but they don't happen automatically. Can you say more about what you mean by that?
Yeah, sure thing. Absolutely. It's correct that the benefits of EAE are not automatic. For instance, EAE makes a single parent company responsible for all, or at least most, of an enrollee's Medicare and Medicaid benefits, as we went over on our slides. And therefore, DSNPs are incentivized to streamline care, improve care coordination, and avoid shifting costs across the Medicare and Medicaid programs. But getting to your question, to fully implement the benefits of EAE that we talked about today, the state would have to build some specific requirements and expectations into its SMAC. For example, if a DSNP and its affiliated Medicaid managed care plan are required to operate with EAE, but the state does not require the plans to use integrated materials to communicate with enrollees about the benefits covered under the plans, those plans will continue to send separate materials describing the Medicare benefits covered by the DSNP and the Medicaid benefits covered by the Medicaid managed care plan. In that circumstance, even though the enrollee is actually getting all of their Medicare and Medicaid benefits covered under a single parent company, they're still having to try and sort out what is and what isn't covered by reading two totally disparate sets of materials, which admittedly can be very confusing. However, if the state simply requires these plans to implement integrated enrollee communication materials in addition to operating with EAE, enrollees can get one set of materials that explain all of the benefits covered by both Medicare and Medicaid instead. So I hope that's helpful to explain a bit more about what a state need to do to fully implement EAE.
Thank you, Ryan. That is very helpful, I think. And I'm going to take the next question that I see myself, because I think I can speak to it. We have a question that asks how default enrollment fits in to EAE. So default enrollment is a separate enrollment-related policy whereby states can work with DSNPs to promote enrollment into a DSNP if the DSNP meets certain criteria. And one of the key criteria that DSNP needs to meet in order to be able to do default enrollment is the DSNP needs to be operated by a parent company that also operates a Medicaid managed care plan in the state that is enrolling people prior to becoming dually eligible. So if Company A is enrolling people in a Medicaid managed care plan, and Company A also operates a DSNP, and Company A's DSNP meets a variety of specific requirements regarding their star rating measures and getting approval from CMS, et cetera, then Company A can work with the state and CMS to offer an opportunity to their existing Medicaid managed care members when those members first become eligible for Medicare, they can be default enrolled into the DSNP as long as they would remain eligible for the Medicaid managed care coverage through Company A as well. So the way that default enrollment sort of syncs up with exclusively aligned enrollment is that states that have DSNPs that are going to operate with exclusively aligned enrollment can use default enrollment as a way to promote enrollment into those exclusively aligned DSNPs, as long as those exclusively aligned DSNPs also operate Medicaid managed care plans that enroll those people prior to becoming duly eligible. So there's a lot of sort of moving puzzle pieces that need to line up there, but when those pieces do line up, you can really create some continuity of care for those folks across the Medicaid spectrum and into that Medicare and Medicaid coverage when those people become duly eligible. So I hope that's a helpful introduction to that. That is definitely one of the topics that ICRC and MNCO provide specific assistance on in direct one-on-one TA to states that are doing these kinds of things. So highly recommend connecting with us about how to leverage both default enrollment and exclusively aligned enrollment in conjunction together as well. So the next question I'm going to throw back to Ryan again. We got a question asking if we could briefly go over the aligning DSNPs EAE contracting strategy again. Ryan, would you be able to speak about that one more time?
Sure thing. Happy to pitch in here. This is when the state selectively contracts with DSNPs that have affiliated Medicaid managed care plans. In other words, these are plans offered by the same parent company. That's really the key here. And then through its SMAC, the state requires those DSNPs to operate with exclusively aligned enrollment. And when you've got that, the state's duly eligible individuals, they've got two plans, one for Medicare and one for Medicaid. But again, the key is both of those plans are offered by the same parent company, and the state requires those plans to team up and work together to streamline enrollees' experiences in those two plans. Of course, that's not the only contracting strategy out there. There's also, as we went over, there's contracting directly with DSNPs to cover Medicaid benefits. There's another strategy around using separate PBPs for aligned and unaligned enrollees. And there's different scenarios in which one of these make more sense than the others, depending on the state's DSNP and Medicaid managed care landscape and structure. So I hope that's a sufficient brief answer. And of course, we can help think through more of this around what types of strategies work for particular state scenarios.
Thank you, Ryan. And I'm going to go ahead and answer the next question myself, which is, will CMS offer states any financial resources for modifications in state Medicaid enrollment systems, since it is such a large undertaking? And I'm going to go ahead and interpret this question as, is CMS offering states specific financial resources for enrollment system modifications specific to the implementation of exclusively aligned enrollment? And so the answer to that right now is that there is not specific funding for states that is specific to the implementation of exclusively aligned enrollment when it comes to Medicaid enrollment system modifications, though I'm sure this is something that the folks on the line from CMS are happy to take back. I know that often the devotion of new financial resources like this requires congressional approval, so it's not something that CMS can just do of their own accord. So I want to note that. But I also want to note again that this is an area where ICRC and MMCO's direct one-on-one technical assistance for states can probably be very helpful because there are a variety of ways that states can leverage different kinds of FMAP rates in upgrading eligibility and enrollment systems. And those specific FMAP rates for those kinds of eligibility and enrollment system upgrades within Medicaid are not specific to implementation of exclusively aligned enrollment. I want to be very clear about that. But in many cases, states may be undertaking other eligibility or enrollment system upgrades to accomplish other goals in Medicaid, and thereby able to leverage some of those 75% or 90% FMAP rates for some of those purposes. And you might be able to build in things that you're doing for EAE into some of those system changes. I also just want to note that EAE does not always have to require large system changes. And that's another reason why I suggest connecting with ICRC and MMCO for some direct one-on-one TA if your state is thinking about the possibility of implementing EAE. As Ryan presented today, there are these 3 different contracting strategies that can be used to implement EAE, and they all carry sort of different steps and methods, and some of them are more intensive than others in the steps that you would take to implement them. But some of these methods might not necessarily require any systems changes at all at the state level. So I think it's valuable and important to sit down and have that one-on-one conversation with MMCO and ICRC about your interests and the steps that you'd like to undertake so that we can see if it might be possible to implement EAE in a way that perhaps wouldn't require you to actually make any system modifications as an initial approach. So hopefully that is helpful, and look forward to hopefully maybe speaking to whoever asked that question more in the future. The next question, I think, goes to Diane. I think this slide was in your section, Diane. The question is, what are the lock-in policies that you referenced on slide 35? Diane, I think you're on mute.
There we go. All right, thank you, Erin. The Medicaid lock-in policies that I was talking about on that slide are the policies that states may have that require enrollees to stay in a specific managed care company for their Medicaid for a set amount of time. So for example, some states may allow a member to pick a managed care organization during their Medicaid open enrollment period, and then not allow them to change until their next open enrollment period. And states that have policies like that may want to allow exceptions to that policy in order to facilitate EAE. So if someone chooses to enroll in a DSNP that is operating with exclusively aligned enrollment, the state would want there to be an exception in place so that that person's Medicaid can also move when they make that DSNP choice. I hope that that answers the question.
Thanks very much, Diane. So the next question, I think I'm going to take myself. This question, it says this question may be slightly off topic, but I'm a bit confused on the funding piece of DSNPs. So states provide capitation to the DSNPs, but I've also heard that the state does not fund the DSNP, that Medicare does because the DSNP is a Medicare Advantage plan. Can you provide any clarification on DSNP funding and capitation? So that's actually a very good question, and particularly with regard to exclusively aligned enrollment. When DSNPs operate with exclusively aligned enrollment, that does mean that DSNP enrollees are going to be getting both their Medicare benefits and their Medicaid benefits, either directly through the DSNP or through the DSNP and an affiliated Medicaid managed care plan, as Ryan mentioned, in this aligned plan model. And so what that means is these DSNPs or their affiliated Medicaid plans in those cases will actually be receiving two different streams of funding. The DSNP will receive capitation for the Medicare benefit coverage through CMS, through the Medicare payment. So that Medicare coverage is paid for by CMS. But the coverage of Medicaid benefits, that payment is what comes from the state. So if the DSNP itself is responsible for covering Medicaid benefits, then the state will provide a capitation payment directly to the DSNP for the coverage of the Medicaid benefits for the DSNP enrollees. If the DSNP is paired up with a Medicaid managed care plan that's offered by the same parent company as the DSNP, then the state is going to be capitating that Medicaid managed care plan that is paired up with the DSNP for the coverage of the Medicaid benefits. And in either case, the DSNP is getting that Medicare payment from CMS. So in either of those scenarios, that parent company is getting two separate capitated payments, one from CMS for coverage of Medicare benefits, and one capitated payment from the state for coverage of Medicaid benefits. And then the hope is, because that same parent company is responsible for all of those benefits, that company will have the incentive to actually manage those benefits in a more holistic and integrated way. Because even though they've got two separate streams of payment, they can actually turn that into a single stream of payment for providers, for example, as I believe Ryan mentioned in the section on benefits for beneficiaries and providers. So those plans can then do a lot within the plan to make that experience of care more streamlined across both Medicare and Medicaid. So I hope that is helpful in terms of that question. And I had mentioned previously that, you know, we do have these different approaches to DSNP contracting, and you know, not all of them require system changes. And so this question, I think, is really appropriate and sort of follow up to that. And I'm going to give this question to Haley, since it speaks to her question of the presentation. Haley, it sounded like using the separate PDP approach to implementing exclusively aligned enrollment would really be easier for a state to implement than the other two approaches, since you mentioned that there would be less to do or less to think about for things like stakeholder engagement and data and systems changes. So why wouldn't every state just adopt that separate PBP approach instead of doing one of the other approaches?
Yeah, that's a really great question. So that separate PBP approach can be a useful option for achieving EAE in states that maybe want to have some DSNPs operating with EAE, but maybe they also want to maintain contracts with other DSNPs that don't have EAE, because maybe the state wants to continue to enable aligned enrollment for some DSNPs for some reason, or maybe more likely they want to allow partial benefit dually eligible individuals to still have an opportunity to enroll in DSNPs. And PDP can be a helpful kind of backup option for states that maybe just are not able to require all of their DSNPs to operate with EAE immediately. But maybe the state wants to enable at least some dually eligible individuals to have the benefits that come with EAE. But that said, states that are in a position to require all of their DSNPs to operate with EAE, those states would not typically want to use that separate PBP approach, because that approach supports ongoing growth in unaligned enrollment. And over time, that growth in unaligned enrollment could create a situation where it might be difficult for the state to then switch to requiring all of the DSNPs to operate with EAE if there are so many existing unaligned DSNP enrollees. So whether a state would want to use separate PBPs depends on their current DSNP and Medicaid managed care landscape and what their goals are for near-term and long-term integration. And as we keep saying, ICRC can work with states to provide that individual technical assistance to help states figure out what approach to EAE would work best in their specific environment, whether it's the PBP approach or one of the more comprehensive approaches that we've talked about. A great question.
Thank you, Haley. So Diane, I'm going to give you this next question because it is about the 3 state examples that you gave in your section about the processes that 3 different states used for implementing EAE. The question is, can you clarify if those processes that you talked about were for individuals who are newly eligible for Medicaid, or if they're also used to move a member's Medicaid enrollment to align with the DSNP when a member changes Medicare plans?
Sure, not a problem. The processes that I outlined could be used for people who are newly dually eligible, as well as for those who are requesting a change to a different DSNP. So as I mentioned, dually eligible individuals are going to have a number of enrollment periods available to them for their Medicare, and whether that's the initial enrollment periods, special enrollment periods, the annual enrollment period. So having these processes in place will work for any time that someone is enrolling in a DSNP and the state operates with exclusively aligned enrollment.
Thank you, Diane. This next question I'm going to throw to Caitlin, because I think this pertains to your section of the presentation, Caitlin. If all of the DSNPs in a particular state have affiliated Medicaid managed care plans, and all of the Medicaid managed care plans have affiliated DSNPs, so there's complete sort of alignment between the Medicaid managed care plans and the DSNPs that exist in the state, can we automatically have exclusively aligned enrollment?
Great question. Yeah. So having DSNPs have affiliated Medicaid managed care plans and vice versa is a big step towards exclusively aligned enrollment, but it doesn't automatically create exclusively aligned enrollment. And there are a few important reasons for this. So first, DSNPs and affiliated Medicaid managed care plans must operate in the same geographic area to have the option of operating with EAE. Second, the state must also require the DSNPs to operate with exclusively aligned enrollment in the state SMAC. And so without that requirement, the DSNP cannot refuse to enroll people who will not have EAE. And then, lastly, the plans in the state must also set up enrollment mechanisms and processes to implement exclusively aligned enrollment in order to make sure that each person who enrolls in the DSNP will ultimately have their Medicaid enrollment aligned with their DSNP enrollment. So hopefully that's helpful.
Thank you very much, Caitlin. And Diane, I've got another for you. You mentioned that some states like New Jersey align the Medicaid start date with the Medicare start date, while other states like Idaho allow there to be a 1 month lag between the Medicare and Medicaid start dates. Is one approach better than the other, or why would a state choose to do one versus the other?
All right, good question. So I think that from the perspective of a duly eligible DSNP enrollee, having the Medicare and Medicaid enrollment dates align with each other is going to simplify their transition into exclusively aligned coverage. It's just less confusing for folks, right? It means that the DSNP parent company will be responsible for the Medicare and Medicaid benefits on the first date of the enrollee's DSNP coverage. Having a 1 month lag where your Medicare starts on July 1, but your Medicaid doesn't start through the new program until August 1, that could be confusing for enrollees, particularly if the plan sends them integrated materials that imply that the plan's going to be covering both the Medicare and Medicaid benefits. And so for that reason, in states that do have that 1 month lag, I think it's really important that we educate beneficiaries about the possibilities and the implications of that lag. Doesn't mean that you don't have Medicaid coverage. It's just not through the new plan for you yet. Because aligned start dates, this aligned start date model provides a cleaner transition for enrollees. All of the states that currently require DSNPs to operate with EAE have agreed that aligning Medicaid start dates with Medicare start dates is a better approach when possible. States that do have a 1 month lag, like Idaho and California, didn't consciously choose that approach because they thought it was a better approach to use. It's just that they had to use that approach given their current systems and timelines for effectuating EAE, and that those systems that they have in place don't allow them to align Medicare and Medicaid start dates when they enroll someone late in the month. So I don't think it's really about what's better or not. It's about what can you do and knowing how to react if you can't make those start dates align.
Thanks, Diane. And I'm going to make this one our last question and then throw to Matthew to wrap us up. So this last question is for Ryan. It says, my state has coordination-only DSNPs right now, but we would like to move toward a more integrated model and are interested in possibly pursuing exclusively aligned enrollment. We do cover dually eligible individuals in Medicaid managed care, but we're just starting to carve LTSS into Medicaid managed care. Is there a particular contracting strategy for EAE that would make the most sense for us?
Yeah, thanks for the question. Since you noted that the state already enrolls dually eligible individuals in Medicaid managed care, and secondly, the state is carving LTSS into managed care, we'd be curious to know what level of alignment already exists in the state between the DSNPs and the Medicaid managed care plans. For example, two considerations that come to mind are, do the same companies offer DSNPs and Medicaid managed care plans in the state? And to what extent do those DSNPs and Medicaid plans have service areas that overlap geographically? Those are just two that come to mind. We've got some additional considerations I believe you can take a look at in our slides. And if a sufficient amount of alignment already exists, the state could be set up for, I think it was the aligned plan contracting strategy, where the state selectively contracts with DSNPs that have those affiliated Medicaid managed care plans for dually eligible individuals, and then requires those DSNPs to operate with EAE. However, let's say the state needed to build an integrated program for dually eligible individuals from scratch, so starting from square one. Perhaps the direct contracting strategy would be a better option. All that said, we at ICRC, we can help you think about your strategies so that you can implement EAE depending on the structural elements that you've got in your state. So I hope that's helpful.
Thank you so much, Ryan. And with that, Matthew, if you want to advance to the next slide, we can close us out here. Thank you again to all of our presenters. If you want to revisit today's conversation, the slides and the recording for this presentation will be uploaded to the ICRC website and shared with all call registrants via email. Please do visit our website to find links to past ICRC webinars, as well as a variety of written tools, including those written tools on exclusively aligned enrollment that Diane mentioned during today's presentation. If you are logged into Zoom, we would greatly appreciate it if you would complete the survey that appears at the end of the webinar. And we're looking forward to reviewing your feedback and making changes to future webinars based on what we hear from you. And that survey will also be sent out through email with the recording and slides after the webinar. So thanks again to our presenters, our partners at CMS, and to all of you for joining us today.